This is Dr. Alan Jacobs of the Arthritis Center of Nebraska, and I want to present to you a talk I gave predicting some of the future things in osteoporosis. And I gave this talk on April 13th, 2012. I want to let everybody know that it is very important to treat osteoporosis because our therapies, when used appropriately, give a 50 to 90% reduction in the treatment of fractures. Patients often confuse osteoarthritis with osteoporosis, and so there is a distinction between joints that degenerate and bones that degenerate and break. The medical definition of osteoporosis is that there are two components. First, how much calcium is in the bone, and second, the fragility of bone, in other words, the microscopic structural makeup of the bone that could lead to fractures. It is the hip fractures that occur from osteoporosis that cause a large amount of problems for the individual patient and cost a huge amount of money to our country. There is a 16% excess mortality associated with a hip fracture, and men often die more often than women. The individuals with a hip fracture often have to spend large amount of time in the rehab facilities, and some of them never make it home. And there is a high level of depression and also anxiety about having future fractures after some of these fractures occur. Our bones are very metabolically active. Any bone in your body may have been replaced within the last 3 years, so the bone you had 3 years ago is different than today. This is from the work of two cell types in the bone, one called the osteoclast, which is a very large cell with a ruffled border, and this cell makes a hole in the bone or a resorption pit or fossa. The cells that come along and then fill up the hole are called osteoblasts. The effect of these cells in our lifetime is to, first of all, increase bone mass or bone calcium as we grow taller and our bones get thicker, and this peaks at about age 30. Men have an advantage over women at age 30 because their peak bone mass on average is higher. Then both men and women begin to lose bone, and then at the menopause, women lose bone more rapidly than men due to the lack of estrogen related to the menopause. Then men and women both lose bone density until they die at about 0.5% per year. The statistics show that the amount of calcium in the skeleton when a woman dies is about 40 or 50% of the calcium she had when she was 30 years old. The metabolism of our bone can be shown in this video that displays the microscopic interior of the bone in what is called trabecular bone. And the orange cells represent the osteoclasts that migrate and then make a hole or pit in the bone. And then the normal process is for the osteoblasts to come over that pit and put down new bone. And this is very important in order to keep our bones strong and healthy. Now, recent research has shown that in the environment around the bones, there are cells that are the osteoclast precursor cells, and there are molecules called rank ligand. And rank ligand binds to either the precursor cells or osteoclasts and stimulates the receptor on the surface to activate the osteoclast function. This leads to increased formation of the osteoclasts, increased activation, and also increased survival of the osteoclasts. So there are natural osteoclast activators, and there's decreased natural cell death called apoptosis. Now, in the environment, there's also a molecule that inhibits too much rank ligand. And this is called OPG, which attaches to the rank ligand molecule. and that therefore cannot stimulate the osteoclast. And our medication Prolia also attaches to Reich ligand and inactivates it, so it does not stimulate the osteoclast. Now, if there is an overabundance of Rank ligand in the area of the bone, then we have tremendous osteoclast activity, making very large pits, and there's not enough osteoblasts to make up for all that bony resorption, and we get fragile, broken microscopic bone. As you can see here, the bone is thinning, and many of the inner parts are broken. These cells then are targets for our treatment. So those treatments that target the osteoclasts are called anti-resorptive. And we have one treatment that can stimulate the osteoblast, which is an anabolic treatment. Now, when we talk about affecting the osteoclast, there are three mechanisms. The mechanism of the bisphosphonate medications is to inhibit the enzyme in that lower border of the osteoclast and decrease their function. You can, as I mentioned before, use Prolia, which will decrease the activity of the Rank ligand and therefore decrease the osteoclast function. And then you can also indirectly have an effect on the osteoblast cells, so they can't stimulate the osteoclast, and that's how Evista and the hormones work. There are many risk factors for getting osteoporosis, with ranging from age to female gender to family history, past fractures, race, estrogen deficiency, especially when it occurs during the teenage years, rheumatoid arthritis, smoking, prednisone, and a whole bunch of other medications, including the seizure medicines, and also an eating disorder, organ failure, and various GI and endocrine diseases, most notably sprue, Crohn's disease, and hyperparathyroidism. Now, the FDA is very interested in the ill effects of medication on our bone, and they have a recent announcement about what could happen.
The FDA is cautioning healthcare professionals and patients that proton pump inhibitors may increase the risk of fractures of the hip, wrist, and spine. The drug's labeling is going to be revised to reflect these concerns. PPIs are used to reduce gastric acidity, and they include Nexium, Dexilant, Prilosec, Zegrid, Protonix, Acifex, and Prevacid.
The new safety information is based on FDA's review of several epidemiological studies. These studies found that patients who received high doses of the drugs or who took them for a year or more had the greatest fracture risk. Since most of these patients were older than 50, the increased risk was observed mainly in this age group.
Healthcare professionals prescribing proton pump inhibitors should consider the possibility of an increased fracture risk and whether a lower dose or a shorter duration of therapy might be possible. Patients at risk for osteoporosis should have their bone status managed and should supplement their diets with adequate amounts of vitamin D and calcium.
Patients taking prescription PPIs should understand the possibility of an increased fracture risk, but they should be told not to stop taking their medication without consulting their healthcare professionals. Those using over-the-counter PPIs to treat heartburn should be cautioned not to take these drugs for more than 14 consecutive days and not to take more than 3 14-day treatment courses in 1 year.
So there may well be more investigation of other medicines that can affect bone health. Now, laboratory studies can be very helpful and also for monitoring our treatment. The basic lab would be a calcium level kidney function test called GFR and a vitamin D level. To use the bisphosphonates, it is highly necessary to check these levels. Studies have warned us that there could be side effects if there is a low blood calcium or very low kidney function. And in order to make the medications work effectively, the vitamin D level should be optimized to a value of 30 nanograms per deciliter. Other laboratory studies can be done if the person is very low on the bone mineral density compared to other individuals. There are other tools to evaluate osteoporosis. On the top left, there is an image of an x-ray of the spine, and the regular x-rays can be very useful for looking at a spine that may have had fractures without the person knowing it. This would be an indication for treatment if that were present. On the right upper corner is an image of the MRI of the spine, and this is the preferred examination if someone has back pain with the suspicion of a fracture, when the x-ray may not show any problem at all. A bone mineral density test has become a standard tool throughout the United States, and it measures the amount of calcium in the lumbar spine and in the proximal hip area called the proximal femur. And then we have a new very important tool called the FRAX calculation, which looks at factors besides the bone density and makes a prediction for that individual's chance of getting a fracture. This FRAX calculation is available on the internet to anybody who wishes to use it. And all a person has to do is Google FRAX and you'll be able to find it. It basically is an actuarial calculation that looks at research information and tries to predict a fracture based on a number of responses. This tool will become more widely used if it is actually installed into the bone mineral density machine in the future. The FRAX basically consists of putting in demographic information and then answering the questions as to a previous fracture, a parent with a hip fracture, current smoking, glucocorticoid use, rheumatoid arthritis, and alcohol use. And then the femoral neck density is also put in, and the actuarial tables produce a prediction of getting a fracture in the next 10 years. This would be for any major osteoporotic fracture and then for a hip fracture. And the National Osteoporosis Foundation experts have suggested that treatment be given when the major osteoporotic fracture risk is over 20% and the hip fracture probability is over 3%. There is another tool that can examine the vertebral spine and look for very subtle fractures, and this involves vertebral fracture analysis. A technician examines the spine and puts markers at each individual vertebral body, and then a computer makes an analysis of the various heights in the spine, and when there's a 20% difference, it is called a fracture. The NOF specialists and experts have recommended the following as to when to treat osteoporosis. Whenever there is a spontaneous hip or vertebral fracture, and these include the fractures that don't cause the person pain in the spine. The next is when there is a high frax risk, like I mentioned in the previous slide, at 20% and 3% respectively. And then the time-honored criteria for treatment, which is when the bone density has a T-score in the hip or lumbar spine of less than minus 2.5. And I would like to say these criteria are for when the population is over 50 years old and the women are postmenopausal. And there can be special considerations that could lead a doctor or provider when to treat the osteoporosis. For example, the lumbar spine density is not well represented in the FRAX calculation, and that may take some consideration. And also, the use of PPIs are not part of the FRAX calculation, and there's a number of other risk factors that could be considered. In terms of our treatment, we have the anabolic type, which I mentioned before, which is Forteo acting on the osteoblasts, And those treatments that affect the osteoclasts are the anti-resorptive therapies with bisphosphonates, Evista, Prolia, and nasal calcitonin. We no longer should use estrogen for the treatment of osteoporosis, not because it does not work, but because of its other side effects. These treatments are not all equal to each other. It is generally considered that nasal calcitonin is the weakest of all our treatments and is a last resort therapy. And then the bisphosphonates don't have the same record as to their efficacy in preventing a hip fracture. And the medication called Boniva has not been shown to be able to prevent a hip fracture, for example. The bisphosphonates are the most used medications for osteoporosis, and when they are used orally, they're very hard for the body to absorb and need to be taken with plain water in 30 minutes to 60 minutes before breakfast. The use of Fosamax began in 1995, and its generic name is alendronate. And up until recently, it was the only inexpensive bisphosphonate that we had to use. Actonel is the trade name form of residuinate, and it also can be used every week like Fosamax, but there is a variation of it in which you can use it once a month. Atelvia is residuinate with a special coating, and the purpose of the coating is so that you can take it after breakfast. Boniva is available by both a tablet and also an intravenous injection every 3 months. And Reclast is alendronate, and it's a once-a-year infusion that is given for 3 years. The medication is also used for cancer metastases by the oncologist, and when they use it, it has the name Zometa. The unique thing about the bisphosphonates is that they accumulate in the skeleton and they stay there for many years. When the osteoclast makes a resorption pit, the bisphosphonates in the area cling to the bone crystals and cling very tightly to those bone crystals and stay there. And then when the osteoblasts make new bone, once again, the bisphosphonates in the area cling to the new bone and are therefore incorporated into the skeleton. When an osteoclast comes over an area that has bisphosphonates, they're released once again into the environment. So they stay in the skeleton for a long, long time. And the concern has been for many years that too much of the bisphosphonate can totally turn off the metabolism in bone that could eventually cause brittle bone. And as you can see here, there is a femur fracture, and these have been reported with bisphosphonate therapy. Now, the FDA has been reviewing these medications, and in 2005, they came out with a warning against osteonecrosis of the jaw. This mostly has occurred in cancer patients on Zometa, but there have been a few cases reported with osteoporosis therapies. This is often induced by having a surgery on the jaw, such as a tooth extraction, in conjunction with an infection of the gum or the tooth area. And what you see is an ulcer through the gum with exposed bone from the jaw showing through. In 2010, the FDA gave a warning about femur fractures that are below the hip joint that have occurred with prolonged bisphosphonate therapy, particularly in elderly individuals. This is a warning that occurred in September of 2011 when an advisory panel for the FDA said that with the evidence they had, they would encourage the FDA to limit the duration of use of the bisphosphonates in order to limit some of the long-term frozen bone complications. And they have some other recommendations that also include removing the indication for prevention of osteoporosis from these medications, and that treatment should be halted after a number of years. The FDA has not acted yet on this recommendation, but in general, the FDA does respond to the advisory committee recommendations. So in the eyes of the committee, they are saying that when bisphosphonates are used for several years, the bone strength increases after somewhere between 3 and 5 years, and then it plateaus. It does not keep going up. And so increased use of the bisphosphonates does not lead to increased strengthening of the bone, but instead, with continued use, you get into the frozen bone area where the bone in some regions starts to get weaker, and so continued use leads to complication. So they would prefer that the bisphosphonates used for several years, and they don't know exactly how long, but presumably between 3 to 5 years, in which maximal bone strength is achieved from their use. And then once the strength has reached its plateau, then the medication would be stopped in order to avoid other long-term side effects. So some experts have already begun to think about this, and they decided that it might be a good idea to have on-off treatment cycles so that the bisphosphonates would be used for a period of time, and then it would be stopped, a so-called drug holiday, and then later it would be started up again. So there would be on-off treatment cycles that would potentially give all the strength to the bone without entering into a phase of side effects. So looking at all these facts, the predictions that I feel are justified are that we will perhaps get away from using just bone density by itself to determine who needs to be treated, and we'll begin to use a fracture risk to determine therapy. And the FRAX analysis that I mentioned already seems to decrease the number of young women being treated, and the therapy is directed more at those individuals who are at immediate risk for fractures. And then the prediction would be that we'll either be halting treatment after a number of years, or we may enter into a phase of having intermittent treatment with drug holidays. So if you wish to appear knowledgeable about the long-term side effects of the bisphosphonates, an addition to your note might include a statement such as, the patient denied a non-healing ulcer in the jaw to suggest osteonecrosis of the jaw, a femur fracture while on bisphosphonate or Prolia therapy, or new anterior thigh pains to suggest an early stress fracture from osteoporosis treatment. There were no immediate plans for tooth extractions or dental surgery that could initiate jaw osteonecrosis. Many people who have had fractures from bisphosphonate treatment felt warning signs with anterior thigh pain, so that would be an important question to ask them. And it is the policy of the American Dental Association to have individuals stop their bisphosphonates 3 months before any elective major dental procedure. Once again, I'd like to mention, though, our treatments are very effective in reducing fractures, and the impact of our treatments are much higher than even treating hypertension or even treating cholesterol. So it is very important that we begin to refine our treatments to the best interest of the individual. People who want to learn more about osteoporosis should go to the nof.org site and download a pamphlet called the Clinician's Guide. And I think this would be something that you would find very useful. This has been Dr. Alan Jacobs of the Arthritis Center of Nebraska.